Good afternoon, Penn Staters, and thank you for joining us. I'm Paul Clifford, CEO of the Penn State Alumni Association, and I'd like to welcome everybody to today's virtual speaker session. As many of us are transitioning to living, working, and learning remotely, the Alumni Association is ensuring you stay connected to one another and to the university, and also stay informed. As a reminder, we are recording this session, and today we welcome Dr. Nita Bharti, who will lead a presentation titled Lighting the Way to a Stronger Global Health System. Today's discussion is the latest installment of a recurring series of virtual programming that the Alumni Association is bringing to the Penn State community. We'll be speaking with experts, university leaders, and other Penn Staters who will share their insight and their perspective with you in the coming weeks and months. Additionally, the Penn State Alumni Association offers a host of online networking events, career programs, and webinars, and you can view a full list of these programs at alumni.psu.edu/events. Now I'm happy to welcome Dr. Bharti, who is a quantitative biologist whose research merges conventional field-based measurement and remote sensing to estimate infectious disease risks and implementation solutions. You're gonna explain that to us in just a second, what I've just said there. Since joining the faculty at Penn State in 2016, she has led multi-million-dollar awards from DARPA and NSF to characterize spillover of hendrovirus from bats and identify viable ecological solutions. Dr. Bharti works with industry partners and humanitarian agencies to solve global health problems. Dr. Bharti's presentation will show how human movement is an important factor in the transmission and prevention of infectious disease. That's one of the reasons behavioral interventions are so effective against emerging pathogens like novel coronavirus. Different kinds of movement impact pathogen spread and are regulated differently during outbreaks. These movements are also drivers of the transmission dynamics we observe across a number of endemic infectious diseases in the world today. Dr. Bharti, thanks for joining us, and I'm going to turn it over to you.
Thank you. So it's my pleasure to be able to speak with you today, and I'm just going to tell you some stories about lessons that we've learned from outbreak management in the past. So if we think about pathogens in human populations, we can loosely break them down along a gradient from emergence to endemicity to elimination, and how we manage them and how we respond to them. Emergence on the far left is usually when the prevalence of infection in the population is low, because the pathogen that we're talking about, so the pathogen would have just spilled over or infected a new host species, right? So it's transmitted from its reservoir host species to a novel host species, and that's often referred to as spillover or disease emergence. When we're talking about pathogens that are in sort of the phase of endemicity, we're talking about pathogens where there's not a lot of variation in the prevalence of that pathogen. And in this case, I'm going to be mostly referring to these pathogens in human populations. And then when we talk about elimination, we are talking about pathogens or diseases that we are in the process of removing from a place, country, or region. And the special case of that is eradication, and that's where we completely remove a disease from the world. Some examples and management strategies for pathogens across this gradient is what I'm showing you here. So with emerging pathogens, or when we're looking at disease emergence, we're looking at interventions that are going to manage spillover and reduce transmission in the novel host population. So in this case, in the human population. And in that case, we're heavily reliant on behavioral interventions. And some examples of this are Ebola, which we'll talk about a little bit, and then of course our current experience with SARS coronavirus 2. When we talk about endemicity, we're often dealing with evolution of the pathogen or drug resistance and managing or controlling that. So seasonal influenza is a pretty good example of that. And we won't really talk about that today, but just to give you an idea of what that means. And then when we talk about elimination, we're usually looking at pathogens that are either vaccine preventable or drug treatable. And that means we have pharmaceutical interventions to combat them, right? So if we go from left to right on this spectrum, with emerging pathogens, we're dealing primarily with behavioral interventions. And with eliminating or endemic pathogens, we're dealing usually with some combination of behavioral and pharmaceutical interventions. And those are really our two main routes. Obviously, pharmaceutical interventions require a period of research and development and testing for safety, and then messaging and uptake and rollout. And that takes time. So that's primarily the reason that pharmaceutical interventions are not an option with emerging infections. And some examples of diseases that we consider in elimination or eradication are measles and smallpox. And we'll talk about those briefly. Now, we know that movement drives pathogens, and also that pathogens drive movement, and particularly in human populations. And so I'll sort of frame our discussion a little bit on this framework. And this is sort of a global truth. And if we go back in history and we look at some of the ways that we've seen the spread of pathogens, historically, we can go back to the earliest known occurrences of smallpox, leprosy, and malaria. And what I'm showing you here in these different blue, red, and sort of yellowy orange colors is that the spread of each of these pathogens followed the movement patterns of humans and how they were interacting and spreading out in space at that time. And so we know that that's how the pathogens moved. And we know that people were largely moving in response to environmental factors. And that brings us to what is a very useful framework that we use in epidemiology. This is called the epidemiologic triangle. And this really just recognizes the really important contributions to all disease systems of the host, the pathogen, and the environment. So this really stresses that the context is important for all pathogens and how, excuse me, and how pathogens are interacting with the host and the environment will really determine not just the trajectory of outbreaks, but will also help determine the most effective management strategies moving forward. So what works in one population for management strategies may be quite different from what's effective in another population for the same pathogen. So I'm going to give you a few examples of that, where that has been true and how we know how important these interactions really are. I'll start with the simplest example. We often use measles as really the simplest example for infectious diseases. And part of that is because measles is strongly immunizing. And so people move sort of predictably through susceptible, infected, and recovered classes. And that's what this SIR framework is showing you. And what we know is that from pre-vaccination times, and we're looking here at reported measles cases from England and Wales pre-vaccine, so this is before 1965, what we know is that aggregation of humans increases contacts, that drives up transmission rates and leads to more cases. And in particular, for pre-vaccination measles in England and Wales and globally, we know that these epidemics were driven by school terms. It was the aggregation in classrooms that was really driving up the cases. And so every spike you see in the graph along the bottom is triggered by school terms. And so our management strategies were to, once an immunization strategy was developed, our management strategies were to implement those and administer them before the beginning of school so that children were vaccinated before they went to school and aggregated in classrooms. And that's something that we still do today. And that's been quite effective in large portions of the world. But that hasn't been effective everywhere. And part of the reason for that is that that's not actually describing the underlying mechanism of aggregation everywhere. So school terms in a lot of places describe how hosts interact and would transmit measles, but in a lot of places that's not the case. I'm actually going to go back a slide quickly. And so as recently as 2019, we saw over 400,000 cases of measles, despite the fact that there's a strong, a safe and effective vaccine. If we ignore for a moment the people who actively refuse vaccines and the people who actively refuse measles vaccine, we still see a lot of areas where measles continues to persist, cause infection and mortality. And that brings me to this slide here. So some work that I did showed that a lot of those locations were operating on different sort of economic drivers. So school terms weren't driving aggregations. And in fact, a lot of the aggregations in the human populations were driven by agricultural economies. And so people were aggregating seasonally because of economic forces. And once we sorted that out, that gave us an idea of why the school term strategy for immunization wasn't as effective in some places. It just wasn't aligning with the host and environmental interactions. The way that we figured this out was to use satellite imagery. And a lot of you have seen images like this one, which is a composite image of sort of anthropogenic illumination or nighttime lights. And this gives us a proxy for population distribution and abundance of humans globally. And so when we look at images like this, we're looking at annual composites. And so we can look at the differences between years, between annual composites, and get a sense of, this is one large city, we can get a sense of how these cities change on an annual scale over time. And so that's what you're seeing here is the growth of an urban center over a decade. But in a lot of cases, particularly when we're dealing with pathogens and outbreak management, a year or a decade is really far too coarse of a timeline to understand how pathogens might be moving or how people might be moving. So I developed a way to actually pull apart these composite images and go back to the raw imagery and look at daily and seasonal changes in brightness patterns. So what we're looking at here is 5 cities in West Africa, and these sort of glowy areas at the bottom of each movie panel here show us the actual changing nighttime light signals over the course of a year. And so we're seeing strong seasonal effects. And at the top here, we're seeing the measles transmission rates that are reported for each of these locations. So what this allows us to do is really measure when populations are aggregating and to get ahead of that with management strategies, and in this case, immunization. Some of you will have noticed that there's a city here where there is no measles transmission rate plotted, and that's because this is a city with a relatively weak health system, and they simply don't have the bandwidth to collect data and report it. However, with this type of passive surveillance or population monitoring effort, we're still able to determine when populations are aggregating, when this population is aggregating, and when we would really effectively have management strategies deployed. So in this case, when would we immunize this population against measles? Well, so we can tell you exactly when that would be, despite the fact that we don't have measles cases reported from this location. So there are a number of ways to monitor populations and assess outbreak management strategies, and this is one of them, and this allows us to manage multiple infectious diseases. You can imagine that population aggregations are not specific to measles. They're obviously specific to any transmissible pathogen. And these also allow us to strategically strengthen health systems. So if we know that there are going to be more people in an area at a certain time, we can strengthen our healthcare systems around that. And there's a number of examples for that. You can think about seasonal movements that I've just shown you. You can think about school terms. You can think about university towns. So scaling up healthcare capacity and strength is not uncommon. It's something that we can do strategically if we have the right data. And this involves understanding movement also as part of it. I mentioned smallpox earlier. Smallpox is the only human pathogen that has been eradicated. And this effort also relied heavily on understanding movement and vaccinating people strategically to target mobile populations. So this is a success. This was, smallpox was declared eradicated in 1980. And so that rests heavily on immunization, and immunization being one of the most effective public health measures available today. But it also rests heavily on understanding the interactions between the host, the pathogen, and the environment. And in each of these locations that are shown on this map here, different strategies were used to deploy immunizations to have the greatest impact. So as we shift from sort of the right side of this graph, where we've been talking about measles and smallpox, over to the left, where we talk about emergence. So mentioned, we generally rely on behavioral interventions for novel pathogens because we simply don't have the pharmaceutical interventions available when we're just seeing a pathogen for the first time. And we have a specific category for this on this diagram, right? We know that diseases emerge. We know that for the most part, disease emergence occurs when pathogens spill over from wildlife into human populations. And we know this happens with some regularity, right? So this happened with Ebola, this happened with SARS-1 in 2002. It's happened now with the current SARS coronavirus 2 outbreak. But if we go back to an announcement that the World Health Organization made in 2018, they released a statement about what they thought at the time had the biggest potential to cause public health emergencies. And particularly these are pathogens for which there are no effective pharmaceutical interventions, or there were not at the time. And you'll recognize a number of these pathogens. Certainly Ebola is on here, Nipah and Hendra virus. I work on those quite a bit. And then disease X. So disease X represents basically just the understanding that a serious international epidemic could be caused by a pathogen that we have not yet identified. And I think that's a reasonable explanation for what happened with this current coronavirus. So we hadn't seen this particular coronavirus before, and it has certainly caused a serious international epidemic. So people who say we didn't see this coming or we couldn't have seen this coming just kind of don't know the facts. So we've definitely known that this was a very realistic possibility. This report actually made its way into the popular media. So this news about disease X was widely reported in various news sources, and how to get ready for it, how to manage it. And a lot of this had to do with strengthening healthcare systems and understanding what risk means for these kinds of things. And a lot of our understanding of this involves movement. So one of the ways that you've certainly thought about movement in the context of outbreak management or this pandemic has been in the movement of infectious individuals, right? And so this type of movement is really what we retrospectively try to understand with efforts like contact tracing, which are extremely effective public health measures for reacting to cases. But these types of movements tend to be important when they connect, when these individuals are moving between locations where transmission or prevalence of the pathogen are very different. The other type of movement that we worry about a lot is the movement of non-infectious individuals. So how are susceptible people moving around? This is often overlooked, but it's actually really important. The movement of non-infectious or susceptible individuals and the scale at which they move plays a really important role in our understanding of how to manage outbreaks and our understanding of population dynamics as they drive disease dynamics. So this is also a really important part of behavioral interventions, is understanding the movement of non-infectious individuals, and in a lot of ways, trying to minimize that. Our first line of prevention with behavioral interventions often targets movements, and often targets movements across both infectious and susceptible people. So what we're looking at here is international flights, so commercial flights, not just international, commercial flights. And that's kind of the first thing that we see limited. And we saw that limited for this particular outbreak, where a lot of the flights from high transmission areas were restricted, canceled, or just outright stopped. And then on a sort of a case-by-case basis between other nations, those are largely not what they looked like 3 months ago. The other type of movement another type of movement that's restricted is sort of domestic movement, right? So our ability to move around just even within a nation, that's often minimized during times of outbreaks. So we've experienced that with this particular outbreak. That's also a strategy that we've seen with past Ebola outbreak management, and certainly SARS-1 and MERS and several other emerging infections. And then lastly, the ability to sort of move around very locally. So how do you move around within your town? How do you go to the grocery store? How do you walk down the street? How do you go to restaurants or bars? And our restrictions on that to really minimize the number of daily contacts you have. So, you know, along these types of behavioral restrictions, we started with not wanting to move the pathogen around, or not wanting to increase the number of susceptibles in an area where transmission is high, to really not wanting to transmit within a community, right? So we're talking about restricting movement between communities and within communities to minimize transmission. And that happens when we reduce the number of contacts that everybody has. Another really effective set of behavioral interventions has to do with personal hygiene. So hand washing is a big one that was rolled out for this outbreak. Certainly, obviously, we've seen this for pandemic influenza, seasonal influenza. We saw this for Ebola, SARS-1. Basic hygiene. We also see things like mask wearing. So these are really broadly effective behavioral interventions. And I say that because they work. They've certainly been very effective. They were our only tool against Ebola for all outbreaks before 2014. And there's more that happened than what I'm showing here, but this is the bulk of it. So across this entire region of sort of Central Africa, you know, we've seen Ebola spilling over since 1976, and it remained largely controllable by behavioral interventions. And so you're probably wondering what happened in 2014. This is an important lesson. In 2014, the response to Ebola started in March, a few months after the outbreak began. It's about when it was identified. And this red arrow, so just to give you a sense of what this graph shows, this is time from 2014 to 2015, and this is the number of cases on the y-axis. And so, you know, this is really kind of the peak of the outbreak. The red arrow is showing us the point at which a lot of control efforts thought the outbreak was in control. They thought that it was on its way down, and certainly reported cases were starting to decline. And they let up on the behavioral interventions. And that, as we all know, led to some disastrous consequences. So this is an important lesson for us to know right now. Behavioral interventions are as effective as their implementation. So if we let up too early, we really set ourselves up for a large resurgence, or the potential for a large resurgence. And that obviously is relevant for the outbreak today. We would hate to look back on, in 10 years, we would hate to look back on the epidemic trajectory for this particular pandemic and see a similar pattern, see that we had been social distancing or physical distancing for 2 months, and then we just let up too early. So there's very effective measures when they're implemented, effectively and maintained as necessary. The tricky part about these types of interventions and how we respond to sort of lifting the interventions, or how transmission responds, is that the feedback is not immediate. So I'll explain that. So if we look at this schematic here, the time of onset from left to right is increasing, and our response goes from prevention to reaction as we move up this triangle. So the first things that we see happen are population movement, contacts between susceptibles and infecteds. Some of those result in transmission events, some of those result in cases, and some of those result in reported cases. There's about a 2-week lag between transmission events occurring and cases being reported. What we want to do is get ahead of that with our outbreak management. So we want to know before it's 2 weeks later that a transmission event happened. And so, oops, let me go back. So one of the things that we can do is use passive surveillance techniques to do that. And so we're able to use measurements of, again, anthropogenic illumination or nighttime lights as direct indicators of human population presence and dynamics. We're able to use different indicators on air quality. We're able to use imagery that allows us to detect objects like cars on the roads, to understand something about traffic. And then certainly with any type of public or commercial transit, we're able to understand something about passenger volume. So we're doing that for this outbreak, and we're looking specifically at locations as they start to lift their behavioral interventions or their movement restrictions. And I'll just show you this. So we are also monitoring Penn State and State College in a number of ways, but I am just showing you the radiance or the nighttime lights illumination here. And in September, town and campus were significantly brighter than they were in March. And March is when Pennsylvania and Penn State imposed behavioral interventions and movement restrictions. And what we're seeing in the bottom panel is everything in blue is where town and campus became darker in March than it was in September. And so this is important. What's happening here is that we are increasing our healthcare capacity during this time, as is hopefully everyone. So this is the idea with these interventions, to increase our healthcare capacity and strengthen our health systems during this time of restricted movement and strong behavioral interventions. So this is a sort of an indicator that this has been effective. So at Penn State right now, our light signals are weak so that our health systems can be strong. And so I'll end it there, but essentially we're doing this in a number of locations to be able to understand how passive surveillance can tell us about what populations are doing and how people are behaving. Some of you may know about Ask Sid. You can email your coronavirus questions to asksid@psu.edu. We're answering those questions, and we're answering with short videos at asksid.psu.edu. And then again, my contact information, and I would be happy to just have a discussion now. Paul?
I'm coming back on now. Good.
Hi.
Hi. Great to see you. That was fascinating stuff. If people have questions, you can enter your questions into the Q&A down at the bottom of your screen, and I will get to as many of those as I possibly can. But let's first start with just some of the things that that sparked my interest. Talk about you mentioned the use of a vaccine to eliminate smallpox, but much of the world might not have access to a vaccine like that. And so, how can the WHO put out the claim that smallpox has been eradicated? Like, what stops it from coming back?
Yeah, so that's a great question, and it's the reason that it's been difficult to eradicate other pathogens. So smallpox is unique in that there is no animal reservoir. So smallpox became specific to humans a very long time ago. It's related to cowpox, which is where the vaccine came from, or the initial idea of vaccines came from. But it was a specific viral strain that only infected humans. And when the immunization efforts were really rolled out intensely in the 70s, the WHO and certain other international partners made very, very large efforts to really tackle every corner of the globe. So that's important. The other things that are very important about this particular about smallpox in particular have to do with the vaccine. So that particular vaccine did not require what we call a cold chain, which meant it could just be stored at room temperature. And it did not require intramuscular injection. So it was an epidermal injection, which meant that kind of, not anybody, but you didn't need trained healthcare professionals to do it. You could train up community members to administer that vaccine. There's two more things that are really important about that. First of all, smallpox was easy to diagnose and very visually obvious symptomatically. So it's a very specific visual clinical presentation with the pox. And then the other thing was that the vaccine left a scar. So you could tell who had been vaccinated and who had not been vaccinated. There are a few other specific elements to smallpox immunization and how they were rolled out that made them very effective. But essentially, if it hadn't been done in the 70s, it wouldn't have been done. So there are things that we couldn't have pulled off in the 80s or 90s.
Right. Can you talk a little bit about, much has been made in the media, and I don't want to get into anything political here, but much has been made in the media about the origin of the virus. Are there parts of the world where viruses are more naturally occur and start, or how does that process work in your research?
Yeah, so this is a really interesting process, and it's we say complex ecology underlies a lot of these spillover events, but essentially what we know is that human populations are constantly expanding, and we are taking over more and more parts of the globe. And that means that we are cutting into wildlife habitat. That increases our contacts with wildlife, and every contact increases the likelihood of a transmission event between a human and wildlife. The areas where we think that there are higher risks of spillover events occurring are areas where we see population growth and land clearance, right? So that could be deforestation, things like that. We see spillover events everywhere. So, we can talk about some of the ones that we've mentioned with Ebola and SARS, SARS-2 and SARS-1. But we also know that, so Hendra virus, which is a virus that I work on that spills over from fruit bats, that is exclusive to Australia. Australia has one of the highest deforestation rates of any country in the world. And in the areas where we're seeing that deforestation, that's where we're seeing Hendra virus spill over. Lyme disease is a spillover disease that comes from Lyme, Connecticut. So we see these diseases spilling over. We see pathogens spilling over from wildlife to people anywhere that we're seeing humans have contact with wildlife or sort of wildlife habitat. So, you know, I don't think that there's a specific geography to it, but I do think that having strong local health systems help curb those spillover events from taking off with heavy local transmission and then spreading further.
Absolutely. What I thought was fascinating about your presentation was early in the presentation you used what appeared to be trade routes, right? How people were moving around the world when the only way to move around the world was by ship, right? And then you showed a little bit later in the presentation about flights and commercial flights and how people now readily access every corner of the world. You've seen also a lot in the media about how now cell phones are being used to track human movement. Have you used any of that in your research?
Yeah, so we have used cell phones and mobility traces from cell phones to understand how people move. It's a powerful tool. So phone data are a powerful tool. They're also quite specific. They're really good at solving a really specific problem. Phone data tell us how people move within national borders. Once you cross a national border, your phone data are transferred to a different operator and they cannot be linked up. So we don't see international movement in cell phone mobility traces. And there's a couple really specific nuances with phone data. So phone data are a great representation of phone users in areas where people are using phones. So where there's good cell phone coverage and where there's high uptake of phone usership. They are privately owned by the phone companies. And so one of the limitations that we've experienced with phone data are that we can't share the data with humanitarian organizations or collaborators. We can only share the results of our analysis of those data. So we're a little bit limited that way. The other thing that's really important is that in a lot of places where we see spillover events happen, or we really would like to know how people are moving, there isn't a huge amount of cell phone usage. There's not great uptake and there's not coverage. And so it's a great tool in certain situations, and we use it when it's appropriate.
Yeah. So you used the example of the spread of Ebola in West Africa, and how it appeared that the disease was under control, that the curve had started to flatten, and then they held up and kind of eased off of the mitigation strategies. And we're starting to see some of that now, right? New York Times has been cautioning that although New York City has been seen a decrease in cases, that curve doesn't necessarily relate to other parts of the country, right? And so, can you talk a little bit about, you know, when we start to let up on these on the mitigating strategies? How we should be going about doing that, how we should be thinking about that. Is it something that can be done regionally, knowing how mobile Americans are? Talk through some of those, the thought pattern of our leaders that they're using right now.
Yeah, so this is a really important concept. And what we are currently seeing is that states are rolling out their own regulations. And if we talk about Pennsylvania, we have county level or health region level restrictions enforced and lifted. And I think that the important thing about lifting restrictions and enforcing restrictions is that one size does not fit all. So what we see with almost all outbreaks, and what we're seeing with this outbreak, is that they tend to start and grow large in urban areas. So high population density, high contact, high movement urban centers. And then they shift to sort of secondary cities and suburban areas. And they kind of move further down into these more peripheral areas or areas of smaller populations or less dense populations. And that really reflects the connectivity between human settlements, right? So cities are really connected and they get outbreaks first. What we're starting to see now is an uptick in cases in rural areas in America. And so if we're lifting restrictions at statewide or countywide levels, we are actually smushing together management strategies for rural areas and urban areas. And that's not the most effective way to do it if we're seeing these lagged outbreaks as we would expect to see. So the statewide restrictions that are lifting in some cases are ill-advised. They're not necessarily in line with epidemiological predictions. And in some cases, I think just a more careful spatial scale management of restrictions would be wiser, certainly in areas where we're still seeing upticks of cases. The really critical thing that I mentioned during the talk was that the whole point of these behavioral interventions and movement restrictions is to strengthen our healthcare systems, so that instead of overwhelming healthcare systems when the outbreak is still small, we've actually strengthened our healthcare systems to be able to manage more cases and treat more people so they have healthy outcomes. That has not quite rolled out in the US the way that we had hoped. So we're still well below where we would like to be with testing capacity. And that means that we just don't have a sense of where the virus is or who it is infecting or who it has infected. That makes it very hard to target our management efforts more specifically. We still are a little bit stuck with these more general behavioral interventions because we don't have the data for that specificity. And that's something that, we had hoped that we would have by now, and that certainly it's not logistically impossible to have had by now, but has not been put in place.
Yeah, just like you said, not every instance or every part of the country is kind of created equally in terms of the impact of this disease. Not every pandemic type, not every pandemic is created equally either, right? And so what may have worked with Ebola, like the numbers that you showed with Ebola, are nowhere near the numbers that we're experiencing with this. And so how far can we look at past mitigating strategies to inform what we're dealing with now, because it's so new and so different than some of those other things that we have faced?
Yeah, so I think one of the critical differences between Ebola and this current coronavirus outbreak has to do with the fact that with Ebola, we generally knew who was infected. And people were generally not infectious until they started showing symptoms.
Right.
With SARS-1 was actually a better transmitter than the current coronavirus, than the current SARS coronavirus 2 that we're dealing with, but it was also very symptomatic. And so people were not asymptomatically transmitting the virus nearly as much as they are with this one. And that has been one of our biggest obstacles, is with the inability to understand who is infected and who is transmitting. Because of these asymptomatic transmission patterns, we are really sort of hamstrung in how we manage this outbreak without large-scale testing, which we haven't ramped up yet. So I think that that's a really critical difference, just kind of knowing the landscape, knowing the prevalence, knowing the incidence. We right now, our data are focused on severe cases that have sought healthcare. That really is the bulk of our reported case database right now. We don't have a good sense of asymptomatic cases. We do know that through contact tracing of symptomatic cases, we do know that quite an important proportion of transmission has occurred during either asymptomatic or pre-symptomatic infection. And so we really need to roll out testing and really understand where those people are, really get ahead of those transmission events. And that's not something that we had to deal with for Ebola or SARS to this extent. That is something that we deal with influenza. So what we want to be able to do is take lessons we've learned from different outbreaks and apply them to the management of this one and future ones. There's no outbreak that's like any other outbreak. And so we're always learning, but we can still learn from previous experience.
Yeah. So let's go down that path a little bit. There are certainly the social mitigating things that we are doing to stop the spread of this, right? Personal hygiene, stay at home, and those restrictions, I would think, are at least should in part be tied to the development of medicines and the development of vaccines. So first, let's talk about what is the natural time period for medications that once somebody conducts or gets a virus, right? And they need a medication to help them with the symptoms of that or to recover from that. What is the normal development timeline for a medication, and what's the normal development timeline for a vaccine?
Yeah, so I'll go to the beginning part of your question. With viruses, our general strategy is to keep the patient supported and manage their symptoms while the virus runs its course. Right. This is true for almost all viruses, right? Obviously for bacterial infections, it's different, but for viruses, we don't have a great specific medical intervention or pharmaceutical plan. There are some antivirals, which do certain things to sort of prevent the virus from getting into cells. But as far as medication or treatment of viruses, what we really do is try and manage the symptoms. And in some cases, it's the symptomology that really causes the infection and the disease to get out of hand and causes these negative health outcomes in patients. For any new pharmaceutical, like a drug treatment or a preventative, like an immunization or vaccine, the process to go from development in a lab to large-scale production is, it's usually close to 18 months. And the reason is because in that timeline is not just the obvious testing for safety and efficacy, but also the actual logistical scaling up of production. So we don't have drug or vaccine facilities sitting around waiting to make something that hasn't been invented yet. Right. And so that becomes a part of that timeline. There are, and that's after, even if we solve the problem scientifically, which right. is a whole nother issue, and we come up with a really effective thing, a really effective pharmaceutical intervention, scaling it up and getting it out is a part of that timeline.
Yeah, and we've actually seen some of that with some of the antibody testing, right? Where some of the regulations have been removed, right, so that there could be more speed to market with some of these things, and yet the accuracy of some of these tests have proven to be almost at dangerous levels, right? If it's 16% false positive, you're giving people, they're saying, yeah, you could go back to work, and they could unintentionally be infecting other people. Can you talk a little bit about antibodies for the virus and where we stand on antibody carriers are immune to reinfection and how those tests are being applied?
Yeah, so I'll start with the idea of the test development. So a lot of the safety regulations that are applied for drug treatments or vaccines are not as stringent for testing, right? So we're not actually putting anyone at risk with testing. It's what we do with the results and the knowledge of those results that can put people at risk. And so we have some we have measures of sensitivity and specificity, which tell us how frequently you would expect to get false positives and false negatives from these tests. But that is also a process, because that means we need a true test to compare those results to. That is a factor in developing these tests and really assessing their accuracy. So those roll out to market much more quickly than drugs or immunizations or anything that would put an individual at risk. The dangers with some of these ideas of like immunity passports that people are talking about. So, well, if you test positive, if you show antibody exposure, then you are free to move about the planet because you've already been exposed and you're immune. So that's not true. We know that that is something we don't know. We don't have a perfect link between somebody having antibodies and that person being immune if they're challenged with the virus. Right. So all we know is that if somebody has antibodies, that they've been challenged with that virus or something quite similar. And that may or may not mean that they have immunity to a future challenge with this virus. The false positives may be picking up exposure to another coronavirus, and it may not be protective. So there's a lot of room for misinterpretation and error with those. The other side of that is, even if it's a true positive, even if someone has been previously infected with this virus, we actually don't know what the length of immunity is. Based on everything we know about similar infections, we expect there to be some length of immunity, but whether that's a season or 10 years, we just don't know. And so there's a lot that we need to know before we can implement policy and management that reflects the results of those tests.
Yeah, absolutely. So I know you don't know as much as we would love to know about coronavirus, or at least SARS-2, but drawing on what you know about either influenza or other coronavirus, do you think that there will be variations on this virus? And so, every year there is a new flu shot that comes out, right? Because the strain of flu is a little bit different from previous years. Is that something that we can anticipate, that even if a vaccine is developed for coronavirus, or that it may not be a long-term solution? It may just be the one that eliminates this version of it.
Yeah, so all viruses mutate. All viruses mutate every time they replicate because they don't proofread or error check their replication process. And that's an important part of the genetic diversity that we find in viruses. But not all viruses mutate in a way that makes them antigenically different from strain to strain. So you mentioned influenza. That's a great example of immune escape or immunogenic evolution. So we see that the two proteins on influenza that trigger the strongest human immune response vary rapidly, and they accumulate variation from year to year. So we get a new seasonal flu vaccine every year. For something like measles, we've had the same safe and effective vaccine since the 60s. Measles mutates, and we are able to look at the genetic sequence of a measles infection and figure out where it came from. We can reconstruct chains of transmission that way. But measles does not mutate in a way that impacts the vaccine's efficacy or the human body's ability to recognize prior infection or immunization. So the idea of all that, so really the point of all that is just to say, yes, this virus is mutating. It has not yet mutated in a way that we are seeing reinfection of prior infections, but that doesn't mean anything. We don't really know yet. There's no reason to expect either way that it will or will not do that.
Well, we want to join you for joining it. We want to thank you for joining us today. That's all the time that we have. As a reminder, we'll be hosting additional speaker sessions in the coming weeks and months. And this program, in addition to a wide array of networking events, career programs that are available throughout the year. You can find a full listing on alumni.psu.edu. Thank you to everyone who joined us today, and have a great rest of your day.
Thank you.
That was great. I'm just going to stop the recording.